Good evening friends, Pradeep Pendyala, Professor of Anesthesiology of Buddy. Today I am going to talk about very important and very interesting topic, cleft lip and cleft palate. Friends, cleft lip and cleft palate has huge impact on anybody's life, especially the family and the children. But incidentally, the modern surgical management has totally revolutionized its treatment. It will be very difficult to know whether that person had cleft lip or palate as a child after the surgery. Even if you look for it, you won't find any indication that the person had ever cleft lip or palate. Friends, incidentally, it is more common in males. Strangely, cleft lips are usually on the left side. Now, seeing the incidence, 1 in around 300 to 700 children will invariably will have this problem, cleft lip or cleft palate. You can imagine the magnitude. In the world, there will be thousands of children each year having this defect. Normally, cleft lip usually is an isolated left lip. Cleft lip, when it is involved, the incidence is around 25%, and when it is also have bilateral cleft lip and palate, it is around 10%. And if it is unilateral cleft lip with the same side palate also involving, it's around 25%. So what is remaining? 40%, and this 40% would have cleft palate alone. You can imagine the magnitude of the problem. Now coming to the embryology, let's talk about the embryology, how this problem starts. Cleft lip and palate are caused by growth defects in the first trimester of the life. That means in the first 3 months of the pregnancy of the lady, she develops this problem. The frontonasal and bilateral maxillary prominences fuse to form the upper lip. And the primary palate, that means the anterior to incisive foramen, by around 6th week of gestation. The lateral palatal shelves from maxillary prominences form the secondary palate. That means posterior to incisive foramen during the 7th to 8th week of development, simultaneously when the tongue withdraws from between the shelves. Thereafter, the secondary palate fuses with the primary palate and nasal septum by about 10th to 12th week of development. Any kind of asynchrony, if it occurs during the fusion of various components of this palatal growth, would lead to cleft lip and cleft palate. You can imagine this magnitude of problem, and what could be the causing factor in a lady who develops, in a lady who gives birth to this type of child. Intake of alcohol and drugs such as salicylates, diazepam, phenytoin, phenobarbital during pregnancy, warfarin, corticosteroid, excessive vitamin A during pregnancy can lead to the child having cleft lip or cleft palate. And if the mother has folate metabolism disturbances or increased homocysteine levels, also can have this problem. Maternal smoking increases the cleft lip palate by around 2 times, very high. Radiation exposure during pregnancy also can be a causative factor. Teratogenic agents like solvents on people who are working with the agricultural chemicals can have this problem. Viral infections like maternal rubella, it could be also familial. Risk of malformation is 3 to 5% more in affected parents. That's the problem. And age of the parents. More the age, more the chances of offspring having this problem. And occupation of the father. If the father is working in agricultural field, chances is very high. Now, what are the symptoms? Very obvious, cleft lip and palate results in difficulty in feeding during birth due to impairment of suckling and swallowing. So there will be malnutrition, nutritional deficiency, or even anemia in the child. And there could be regurgitation of fluids and food which can lead to chronic upper respiratory tract infection or aspiration. Incidentally, if the child has cleft lip or palate, they would have problem in phonation of certain alphabets like P, R, T and D. They cannot pronounce. The phonation, the speech will be defective. They cannot pronounce, speak out words starting with P, R, T and D. You can imagine the magnitude of trauma, mental trauma, psychological trauma, beside the awful look which the child has. You can imagine the trauma, mental trauma. And especially, I'll tell you something very important. This can be detected easily by about ultrasonography, by around 18 to 20 weeks, whether the child is having cleft lip or not. The doctors are supposed to tell the patient's parents about this defect, because it's a huge preparation, mental preparation of the parents to have it or not. See, telling the sex of the child is very illegal. You are not supposed to tell. But this type of deformity which is likely to occur, the parents should be mentally be prepared to accept it. By the way, it's better not to have abortions, although they have the option open. But as I have mentioned, the present fantastic surgery revolutionized the looks of the child. After the surgery, it will be impossible to know that the child had ever such defect after the surgery. So I would say better to continue. And what are the other problems? See, such thing doesn't occur alone, especially cleft palate. It occurs as a syndrome. Syndrome means few things occur along with cleft palate. Like 80% of cleft palate are associated with Peary-Robin syndrome. What is it? It's a syndrome where the child, besides having cleft palate, would have micronathia, glossoptosis, means huge size of tongue, and the lower jaw will be receded, small size, that is not micronathia, and glossoptosis. Glossop means tongue, is huge size of tongue would be there, underlying syndrome, and usually it will be easier to intubate later in life. That is the thing. More the age of the child, it will be easier to do intubation. Whereas other syndromes like Treacher-Collins syndrome and all, intubation may become very, very difficult as the age increases. Strange but true. In Peary-Robin syndrome, later age, as the child grows older, the intubation will be easier. Whereas if the child is going to be operated at the age of 6 months or 3 months or 1.5 years, it will be very, very difficult for the anesthesiologist to intubate the child. But the later, if it is operated, it will be very easy. Whereas in Treacher-Collins syndrome, it's a very similar syndrome which has micronathia, choanal atresia, that means those nasal openings are missing. 28% are associated with cleft palate. In this, ear and eye malformation also might be there, but incidentally intubation may be much more difficult as the passing of age. That means the older the person or the child will be more difficult to intubate. Other similar syndromes are hemifacial microsomia and cardiofacial syndrome. This is a very interesting syndrome. It's also known as catch-22, catch-22 syndrome, and also DiGeorge syndrome. You must have heard DiGeorge syndrome. This will have abnormal chromosome 22. And this is, they write 22L and 11.2. That means the long arm of the chromosome of 22 will be defective, as well as 11.2. What is it? It signifies the location of the defect in that particular chromosome, long arm of the chromosome. So that signifies, just like the Google location, you tell. Similarly, it's known with the fish test. Fish is nothing, fluorescence test. One kind of fluorescence test will detect this deformity of gene. That is it. There are other syndromes. Incidentally, there will be severe decrease in the calcium levels also. In DiGeorge syndrome, there will be microcephaly and microstomia. Nasal bridge would be flat, small ears and short stature. Immune deficiency would be there. Congenital cardiac disease and laryngeal and tracheal anomalies would be there. All these things. And this is known as I said, 22q and 11.2. Q is nothing but 22 is number of the chromosome, 22nd chromosome is defective. Q is long arm of the chromosome is defective. Similar syndromes are Down syndrome, Stickler syndrome, and fetal alcohol syndrome, Klippel-Feil syndrome. And what is the appropriate age when the surgery is to be done? In our times, we used to be told that at 3 months of age, cleft lip should be operated and cleft palate should be operated at around 6 months. But as of now, the latest thing is surgical correction of cleft lip is done between 3 to 6 months of age, and cleft palate repair is normally performed between 9 and 18 months of age. That is it. Now, incidentally, the presence of micronathia, retrognathia and prominent premaxilla and bilateral clefts in palate should alert the anesthetist to the possibilities of difficult laryngoscopic view. Difficult laryngoscopic view is more frequent than difficult face mask ventilation. That means face mask ventilation may be okay. You won't assume that there will be a problem. But the moment you do laryngoscopic view, then you will understand the magnitude of the problem. There will be a huge problem of intubation in these patients. The presence of bilateral and unilateral microtia have 42% and 2% incidence of difficult intubation. Majority of the patient will end up with difficulty in intubation. That you should be mentally be prepared and do the alternative arrangements for that. There is no second thoughts about it. Well, the syndromic patients with craniofacial anomalies may be difficult to mask ventilate also or to intubate. Hence, preparations and planning for alternative techniques of airway management must be done in these patients. However, LMA placement might disrupt previous repaired cleft palate. So be careful. You can definitely try LMA. The airways can be secured by fiber optic intubation through a laryngeal mask airway or LMA in these patients. Other useful intubation aid include video laryngoscope and pediatric gum elastic bougie. This is it. And friends, children with cleft lip and palate may present with airway obstruction during anesthesia, induction by the face mask. This can be remedied by insertion of an oropharyngeal or nasal airway. You should always put one airway, nasopharyngeal or oropharyngeal. And application of CPAP, continuous positive airway pressure. Also, the tongue may get impacted in the clefts of the palate and present as airway obstruction. So, it is safer to maintain the patient on spontaneous ventilation until an endotracheal tube is placed. That should be always the motto of your management. Now, few words, already have crossed 14 minutes of this talk. I'll finish with the anesthetic management. Actual monitoring is nothing but the standard ASA monitoring. Induction, preferably inhalation anesthesia, induction with 100% oxygen with sevoflurane, I would prefer. Otherwise, use RAE. RAE is nothing but ring Adair Elvin endotracheal tube, use it. And you can use intravenous anesthetic induction also in few patients. And a throat pack is inserted in the cleft lip repair surgery in order to prevent aspiration. Incidentally, there could be aspiration of blood also in such patient. For cleft palate surgery, a mouth gag that's known as Dingman retractor or Kilner dot mouth gag is generally inserted by the surgeon, which provides good surgical field exposure. The mouth gag has a slot for endotracheal tube, which prevents the occlusion and stabilizes the endotracheal tube. Position is very simple. Positioning and padding is critical during these surgeries. The head of the child is hyperextended and placed in a head support. Maintenance of anesthesia is using normally opioids and muscle relaxant and intravenous or inhalation agent. Emergence and postoperative management, we have to be careful about airway management, postoperative also, and during emergence. And postoperative pain management is very important. Multimodal analgesia consisting of opioids, paracetamol or nerve blocks is adequate. One thing very important I wanted to say in the conclusion, the bilateral infraorbital nerve block can be administered in cases of cleft lip repair, alone or in addition of parenteral analgesic. That works wonderfully well. Bilateral infraorbital nerve block. And bilateral suprazygomatic maxillary nerve block for cleft lip repair, and palatal nerve block, nasopalatine or greater and lesser palatine for cleft palate repair, reduces postoperative pain. I hope I have made it very, very clear. Thanks for patient listening. Have a wonderful day. This is Colonel Pradeep Pendyala, Professor of Anesthesiology, signing off for tonight. Until next time, goodbye. Bye-bye.